Venous oxygen saturation, ambition, SvO2, clinical relevance and applications. Introduction to venous oxygen saturation. Venous oxygen saturation measures the balance between oxygen delivery and consumption. It reflects whether the tissues are receiving enough oxygen. Types of venous oxygen saturation. Two main types of venous oxygen saturation monitoring. Mixed venous oxygen saturation. Pulmonary artery catheter. Central venous oxygen saturation. Central venous catheter. Normal values, SmVO2 and ScVO2 values help evaluate oxygen balance. SmVO2, 60 to 80%. ScVO2 is usually 2 to 3% lower than SmVO2 in normal conditions. Critical thresholds. 50% indicates serious tissue hypoxia. Physiology recap. SvO2 depends on oxygen delivery, DO2, COX hemoglobin, XSaO2. Oxygen consumption, VO2. Cellular oxygen demand. Measuring SvO2. Methods for measuring SvO2. Pulmonary artery catheter, PAC. Invasive, more data but higher risk. Central venous catheter, CVC. Less invasive, commonly used in ICU. Continuous versus intermittent monitoring. Methods of monitoring SvO2. Continuous. Real-time fiber optic catheters, expensive. Intermittent. Blood draws, less costly. Potential anemia with frequent draws. Interpretation, increased SvO2. Causes of increased SvO2, 80%. Sepsis with AV shunting. Hypothermia. Sedation and anesthesia. Brain death. Interpretation, decreased SvO2. Causes of decreased SvO2, 60%. Shock, cardiogenic, hypovolemic. Anemia, hypoxia, hyperthermia, seizures. Clinical example, sepsis. Case, 10-year-old with septic shock. Initial ScVO2, 55%. Interventions, fluid resuscitation, vasopressors, blood transfusion. Goal, ScVO2, 70%. Clinical example, cardiogenic shock. 15-year-old myocarditis, BP 80-40, cool extremities. SvO2, 45%. Management, inotropes to boost cardiac output. Monitor SvO2 for response. Case, 10-year-old with blunt trauma, hypotension, tachycardia. SvO2 dropping from 60% to 50%. Interpretation, ongoing blood loss, decreased oxygen delivery. Management, blood transfusion, monitor SvO2. Clinical example, major surgery. Case, 15-year-old post-abdominal surgery with low SvO2, 50%. Indicates occult bleeding or anemia. Action, volume resuscitation, blood transfusion. Outcome, improved SvO2, reduced complications. Trends versus absolute values. Trends in SvO2 are often more important than isolated values. ScVO2 is usually higher than SmVO2 in shock. Trends reflect real-time patient condition, complications and risks. Potential complications of catheter placement. PAC, arrhythmias, pulmonary artery rupture, infection. CVC, pneumothorax, air embolism, infection. Key takeaways. SvO2 provides critical insights into oxygen balance. Must be interpreted with hemodynamic parameters. Trends are crucial, useful in shock, sepsis, major surgery. Final thought. Goal, ensure oxygen is reaching and being used by tissues, not just increasing SvO2 numbers.